Start off this morning by welcoming everyone to the Mark and Jean Abel Visiting Professorship in Pediatric Orthopedics. This visiting professorship was established in 2013 in recognition of Dr. Abel's tremendous accomplishments and tremendous contributions to the Department of Orthopedics. And in honor of his commitment to our clinical care, research and education in pediatric orthopedics, this visiting professorship was established by many of our faculty and alumni in his and of course his wife Jean Abel's honor. So Mark has this is actually a bittersweet morning because Mark is about to retire on December 31st, and Mark has been at UVA for 30 years and has had an illustrious career here, not only as the division head of pediatric orthopedics and our main pediatric orthopedic spine surgeon for decades, but his contributions to the health system over the years in his various leadership roles have been extensive. So this is the last Abel visiting professorship where he's on faculty. He'll be professor emeritus moving forward, and I know he'll remain very involved with the future of our department. And we are where we are today because of Dr. Abel and so many of our professor emeriti who built the foundation that has allowed us to grow on, and we're a strong program because of their vision in the past. So Dr. Abel, thank you for all you've done, and congratulations on another visiting professor year. And I'll turn it to you to introduce our visiting professor and friend of the department.
Thank you very much, Bobby. I appreciate that. Yeah, 27 years of service at the university, and it's been a real honor and pleasure. But now it's time to turn things over to the younger generation, and we happen to have one of the real stars here in our state today to talk to us, Victoria Kuester, who's an associate professor at VCU and the head of the pediatric orthopedic division at VCU. She practices at their children's hospital and does outlying clinics in Fredericksburg and Stony Point. And by way of her training, she went to Wake Forest as an undergrad and medical school before doing a residency at VCU, and then did a fellowship at the AI DuPont Nemours Children's Hospital in Wilmington, Delaware, which has a long track history of illustrious leaders in pediatric orthopedics. And so we're really lucky to have her in this state. Furthermore, her broad base in training allows her to practice across the spectrum of pediatric orthopedic conditions. And I thought that would make her a really good educator for us this morning. I recognize that times are challenging, and I really appreciate that she agreed to do this for us. And I appreciate Bobby and Winston putting together the curriculum. Winston for making sure that we had all our AV stuff, and the residents, Michelle and the chiefs who've helped to pull this together. So Victoria is going to be talking about two different topics. The first one is limb deformity, and the second will be about her experiences in developing countries delivering pediatric orthopedic care. So let's go ahead, Tori, you're on.
All right. Well, thanks again for having me. It's an honor to be with you guys, even though I can't really be with you. But I hope this gives some people some insight. This talk is really, it's a broad spectrum of hopefully some little nuggets for those who are even PGY 1 and 2s, and then those who are, more experienced, and from everything from Ps to sports and joints. So we get started. My objectives here for the morning are kind of to review what the evaluating alignment in kids, but also it really works for adults too. And some of the other things I'll talk about. And we'll discuss causes of malalignment, measurements of malalignment, and some treatments. So again, it seems like a large topic. It is a little bit. Hopefully it won't be too much. But it is meant to be interactive. So I will be calling on the residents some. So hopefully you'll be ready and willing to talk. So again, we'll start here as kind of some of the basics. And I'd like for maybe Neil is on. Neil, I'd like for you to show me or tell me a little bit about what you see in some of these pictures and what you notice. Neil,
Yes, ma'am. So
okay,
yes, I am. So looking in these pictures, definitely see, given the talk, limb length discrepancies jump to mind. I think on the left there, it looks like probably a pediatric patient that's being supported by a family member from behind as they're ambulating with a little bit of in-towing or turning in of the left foot as they're walking. So thinking about their foot progression angle. Also on the picture on the right, seem to be similar with kind of the more of the knees turned in there, so maybe a little bit more of the femoral neck shaft angle, but definitely would want to get just a little bit more of an exam and some imaging to kind of determine what may be causing that.
Okay, good. So yeah, you really picked up on the fact that, in towing, we see here 2 different ages of kids. One's more of a toddler, one's a little bit older. And so then we want to kind of talk about some of the basic causes. Maybe one of your peers is Thomas around? Is he there?
I am on, yeah. So there can be a number of different causes of in-towing. And like Neil said, want to get some more imaging to evaluate, but thinking of things like femoral anteversion or tibial torsion.
Good. Yeah. So those are 2 of the main things. And then the third?
Like a metatarsus adductus.
Yeah, exactly. So think about the foot, the tibia, and the femur. And then we'll talk about how, common they are at different ages. Thomas, when do you think the tibial issues are more common?
I'm not actually sure.
Okay. All right. We'll go into that. And then we'll go into some of the treatments and should you look for other problems. So if you see in-towing on one extremity versus both extremities, you might want to look for neuromuscular issues. Child with CP, you might be the first one to pick up on something with that. So different things to pay attention to, looking for the underlying issue. So as you guys said, here are the main causes of in-towing. And we're going to kind of go through those relatively quickly. But metatarsus adductus, the foot deformity, just basically curved foot of the forefoot in from the hind foot. This should be better by 18 months. It's really a positioning problem in utero. And that's something that you need to keep in mind because some people might not have outgrown it and may still be part of an issue. So when we're going to look for these things in patients, you need to think about what's the best way to examine them for it. How about Alyssa? You there?
I think sometimes, yeah, sorry. I think sometimes it could be helpful if a patient's parent took a video of them at home. That could be one thing that could help you. And then if they're in the office with you, sometimes I know you can lay them prone, and depending on what you're looking at, if you're looking at femur versus tibia versus foot, you can try to isolate that versus the other causes.
Yeah, you're right on. So that's where I was headed. And I think, putting them prone is the best way to look at all these things. You can look at their foot alignment, make sure they don't have something like metatarsus adductus or another foot ailment that's going to throw it off. Certainly, and looking, as you said, looking at their gait is key as well to be able to try to figure out what's going on. But here in this prone position, you can look at their foot and their heel bisector angle. to determine, metatarsus adductus and where that line goes. But if their foot is normal, then you move on up, look at their tibia, the 5-foot angle. And then you can also look at their femurs and how much rotation they have. Now, this doesn't tell you exactly their femoral anteversion, but it can give you a good idea of what that is comparatively. And the more internal rotation one has, usually the more femoral anteversion they have. That can be a little different when somebody's really hypotonic or has a lot of elasticity, but in most cases, that's the case. So then we have to talk about what's normal. And that's when you talk about limb alignment, knowing what is normal is really key to be able to then determine what is truly abnormal. So Pearson, do you have any idea what normal 5-foot angles or femoral internal rotation might be?
Pearson's not going to be on, Tori.
Okay. All right. Great.
Maternity leave, or paternity leave.
Oh, okay.
A brand new baby in the family.
And how about, okay, moving up, how about Tim?
Yeah, so a normal 5-foot angle is going to be between 10 and 15 degrees. And in terms of, okay, yep.
Yeah.
And then in terms of internal and external rotation, internal rotation maybe to about 50, 60 degrees.
I'm sorry, what did you say for the femoral rotation?
About 50 to
50,
60.
okay, good, good. So yeah, and that's in, the adolescent or adult, what's normal, but in infants, it's going to be different. And when a child is in utero developing, the limbs actually, as they form, they're in an internally rotated position. So when they come out, the idea is that those limbs then externally rotate as they grow. But so for infants, they have a pretty normal internally rotated tibia. And that can be a lot. There's a large spectrum upon which can be normal for these kids. So their mean is actually 5 degrees internal when they're young. And then, as you said, more like 10 to 15 when, in an adolescent or an adult. And then for femoral rotation, yeah, you said, 50 or 60 degrees, and that's very normal. Anywhere between 20 and 60 really after the age of 10 is fairly normal. And external rotation is about 30 to 60 for normal. It's a little harder to test, I think, in the prone position, but that is normal. All right, good. So tibial torsion, what's kind of the natural history? Usually this gets better. Again, as I said, as kids grow, as the bones grow, they actually go through a normal externally rotating process, and typically is better by 5 years of age. What is their treatment? In most cases, nothing. And surgery is rarely needed, but it's more frequently needed in kids with cerebral palsy or spina bifida because they tend to not undergo that derotational process as well. Unfortunately, we found bracing is not effective, but that's probably fine because the majority get better anyways. So 20, 30 years ago, kids were braced for tibial torsion, and we determined it really didn't matter. If they're going to get better, they're going to get better. But what if they don't outgrow it? So then what do we do? If some parents feel that it's more of a cosmetic or functional problem, then we can consider surgery. And this picture is someone who's an adolescent, a little bit older, but certainly we can do the same thing when they're younger. So usually, when they're smaller, we can use K-wires, we can use a much smaller plate. There's a variety of ways of doing it to improve their alignment and hopefully their function. But I really, a lot of parents get, when you tell them what needs to be done, and if it's really just a cosmetic issue, some are like, no way, Jose, I'm not going there. But and then the question of, do you have to derotate the fibula as well? And there are some articles out there that look at if you need to or not. Usually, I'd say most people probably, if you have to derotate more than 25 degrees, then you will consider derotating the fibula as well, so that the joint, tibiofibular joint, doesn't get off. But there are some articles to show that will remodel with time as well. Femoral anteversion, so this, is seen in the older kids. Hopefully they've outgrown their tibial torsion. You see it a little bit more in, 5-6-year-old range, and sometimes more. Again, usually it gets better. This is a normal thing that we see in kids. And as they're growing, the femurs externally rotate even more. There's no direct medical sequela to just femoral anteversion. And again, treatment really has to, be thought about if it's cosmetic or functional. But there are a lot of people walking around with femoral anteversion and in-toeing because of that, without any significant sequela from that. So again, bracing is ineffective, so we don't use that. And the only thing we end up doing or can do is really femoral osteotomies. I tend to wait until they're a little bit older. I tend to wait until they're at least 10. I really try to maximize what, changes are going to happen if the parents can handle waiting a little bit. Because I like to put in a solid femoral nail, intramedullary nail, and then they can immediately weight bear on it afterwards, so they're not in a wheelchair. And if they want both done, we can do both pretty easily. But all right, so I've got another case to look at, and let's see. I'm gonna have, is Ian around?
I am, yes, ma'am.
Okay, great. So Ian, this is a 15-year-old who's been having bilateral knee pain. She walks with her feet actually pretty straight, so she's not really an in-toer, and she looks pretty normal if she has pants on. She doesn't have flat feet, but she's been doing physical therapy, been very frustrated because she's not getting better. She's had MRIs of her knees, which are normal, but when you talk to her in the office, no one's really examined some of what seems like some of the rotational issues, or at least they've never examined her prone. So we're going to look at her in this prone position here. And I'm sorry, the pictures are two different patients, but we're going to look at these. So what do you, Ian, tell me what you see in these pictures.
Yeah, so looks like on the picture on the left, she has a significant amount of internal rotation bilaterally. I mean, she's out to 90 on both sides. And then her thigh foot angle looks to be a little bit excessive as well. I mean, certainly not anything crazy, but definitely over the sort of 10 to 15 as we discussed on the previous slide there.
Yeah, good. So it appears she's got probably increased femoral anteversion and external tibial torsion. Do you know a name for this?
I do not know, I'm sorry.
That's all right. So this is called miserable malalignment syndrome. And if you think about what the kneecap is doing with miserable malalignment syndrome, you think about your femurs internally rotated, your tibia is externally rotated the opposite way, and your kneecap has to track along that. And as you flex and extend, they're doing the kneecap's kind of shifting almost like a zigzag. So you really tend to have some patellar issues with femoral anteversion and extratibial torsion. And so this is definitely something that, a lot of sports doctors really have to be aware of as well. They may not be having a meniscal problem, they may not be having ligamentous issues, but they may have an alignment issue, and that's why they have their knee pain or their patella pain. Or even just looking at patients that do have some patellar instability, it's really important that you take a look at their alignment. So what do you do if they have it? Well, physical therapy can help some kids with it. It doesn't change the underlying issue, but when they get nice and strong, some of them do improve and get better. So there are a fair amount of people who are walking around probably with this, but don't necessarily have an issue. But the only way to really fix it is to do femoral and tibial osteotomies, which, as you can imagine, that's it's a huge deal to do. But here, let's look at this patient here. And if you notice, when this patient puts her feet together, her knees are really internally, aligned. When she puts her kneecaps straight out, her feet are very external. So kind of like a duck walk. So in this type of patient, this is a patient with a femoral anteversion, significant increased femoral anteversion and external tibial torsion, again, miserable malalignment syndrome. So how do we fix that? As I said, femoral and tibial osteotomies, it's a big surgery. I've done them together before or bilaterally. That can be difficult because they're basically, they're basically in a wheelchair for a little while until they really feel better. They can weight bear, but it's tough. So I find doing them one side at a time is usually a little better because they can at least get up and get around a little easier. But as you can see, you can do, a nail. You could use a plate, but again, hopefully they're older at this point and you can use a nail in the femurs. And most people do a distal tibial osteotomy to correct that. All right, anybody have any questions about, any of the residents have any questions about alignment for rotational malalignment?
Ask a question.
Go ahead, Winston.
So what do you worry about what the rearrangement of her alignment does to her hips? So she looks a little shallow on the right, especially. Do you worry about what it does downstream or upstream, I guess?
Yeah, that's a good question. So typically no, it doesn't really, I don't think, change it that much. I mean, I guess if the patient had a lot of dysplasia, then I could be a little bit more concerned about what that's going to do. But yeah, so I mean, you do have to look upstream and make sure that this isn't going to be a hip that you're making worse by doing that. Because it's a good point.
Can I ask a question or make a comment? I'm glad you brought up the anteversion knee pain issue, because we had a classic patient when I was at Connecticut Children's that came through the motion analysis lab. I think she was a teenager. She had already had 2 arthroscopic procedures for knee pain, and no one had ever checked her hip rotation prone. And it turned out it was pure anteversion. So with femoral osteotomies, her knee pain went away. And I feel like a lot of the kids, especially the older kids, they lose that lack of external rotation as they get older, and that's a big problem for them. So they keep the internal rotation, but they lose that external rotation.
Yeah, that's a good point.
And then I had another question for you. Have you ever seen the opposite, with retroversion? I've seen some of these kids with retroversion who are trying to correct themselves, and they come in with pain specifically at the tensor fascia lata muscle area. Have you seen some of that?
I haven't. Now maybe it's seen me and I haven't seen it.
So when they fatigue, they get this pain right in the TFL muscle.
Okay.
Trying to compensate for the retroversion.
Okay. And have you done osteotomies for those, or?
If they beg.
Stretching? Yeah.
Hey, Victoria, this is Dave Dedock. I'm one of the sports guys and deal with this problem for patellofemoral issues, do a lot of patellofemoral surgery. Mm-hmm. So some people in the sports world, I mean, we recognize this problem with the anteversion, but it's a big correction. And certainly appreciating the fact that you have to do something to the tibia as well is very important. Some people are talking about doing osteotomies above the tibial tubercle so that you can correct rotationally right at just below the plateau. Mm-hmm. I don't know how much correction you can get distally. If you've ever done one of those proximally as well, my bias is to maybe move the tubercle over rather than the whole tibia. But very few people have a lot of experience with these. How much correction can you get distally? Do you have any advice on the different approaches to this?
Yeah, so I have not done it proximally, and I do know some people who do it that way, or just moving the as you said, doing a tibia tubercle osteotomy. I guess I feel like to me, in my mind, it's not really fixing the underlying issue, but you're right, it is kind of fixing the problem in that it's a patellar tracking problem. So yeah, I guess I've tended to go to, I need to fix what's really the issue here, but I haven't seen any results with regards to doing them either whether tibial tubercle or probably because they're so rare. I mean, I don't think a lot of people do a ton of them, but
Right.
but I think that's a great point to make.
How
That
far can you rotate it distally?
I'm sorry.
How much rotation can you get distally?
Yeah, well, I mean, if you do the fibula as well, you can get a pretty significant amount. I mean, you can get, probably if you really needed to, 35, 40 degrees. But yeah, but you definitely have to do both.
Thank you.
Sure. All right, well, we're going to move on to some genuvarum and valgum. And so moving on to, let's see, is David around?
Yep, I'm here.
All right, tell me what you see.
All right, this is a young child with genuvarum bilaterally.
All right, good. So yeah, exactly. That's what you see. And can you tell me, I think we talked a little bit if you were around Monday night, what's normal alignment for kids? So in your 12-month-old, what should they be?
I was unfortunately on call during that time, so I don't know the
okay,
numbers.
No problem. All right, let's see. I know Michelle was around. So how about Michelle?
So genuvarum is normal until they're about 2 years old. Then they start to self-correct to neutral about 14 months.
Okay. Yeah, so they start correcting to neutral, usually by 2, they're neutral. And we're going to look at some different ways to measure them and talk about it. And then, sorry, Michelle, what happens at 2? What do they do?
They sometimes even go into a little bit of valgus until they're about 3, and then they start to again normalize. So that is normal, and if you see a child of that age in clinic, reassure the parents if it's not a severe deformity.
Right. And now, and Monday night we saw one very severe at 2 to 3, and that was a little atypical. But very occasionally, you have to look again for what are the underlying issues. So that brings us to what things can be causing this malalignment here. So how about, is Kara around? Or Francis?
Yeah, Kara's doing her ATLS.
Right.
Okay. Francis or Barris?
Francis should be here.
I'm here.
All right.
And so
tell me what some etiologies of genuvarum could be.
I think that malnutrition in the form of rickets is associated with genuvarum. I think also osteogenesis imperfecta is another one that comes to mind.
Okay.
Any real injury that affects the physis can create your deformity. Those are
okay, that's a good start. So number 1, physiologic is going to be, again, the most common that you see in those young kids. And then Blounce is another one that we tend to see. You talked about rickets. There can be other metabolic abnormalities that kids can have. And then skeletal dysplasias, and something also called focal cartilaginous dysplasia is another more rare thing. It's usually unilateral, and the deformity is more distal to the physis than Blounce. But all these different things have to kind of cross your mind when you see a patient with Blounce, definitely many of them being more rare. But I would say the more common things we see are the Blounce. And amazingly, these days, we are still seeing some rickets. I see a lot of kids. I've had 2 in the last couple of months whose vitamin D was less than 5. So it is happening. Kids are drinking less milk and that kind of thing. But so let's talk about a little bit about the physiologic genuvarum. Again, very normal in a young age, typically gets better by 18 to 24 months, and then they become a little knock-kneed. So what about Blounce? Let's talk about the different ages. Basically, there's infantile, and the late form is usually really an infantile, and most people would probably say you pick up on it. It's an infantile version that you picked up on late. and then adolescents greater than 10. Starting with those, infantile Blounce. Let's see. Emmanuel, are you there? Or Max?
Sorry, Emmanuel's out this week.
Okay.
Yeah, I'm here. It's Max.
Okay, Max, tell me what some of the risk factors might be for those who with infantile Blounce.
I think it's more common in male infants. And I would say probably overweight males, and maybe ones that start walking sooner. Off the top of my head, that's all I can think of.
Okay, good. So the overweightness, yeah, it does happen more in Black kids, and they typically will have a family history of it. But you're right, we do see it in a lot of kids who are overweight and they've started walking by 8 or 9 months, and we think that it may be partly a compression of the growth plate at that point, but we don't really know the exact etiology of it. It is typically bilateral in these kids, and as we just discussed, there's differential diagnosis that you have to kind of throw around in your mind of what else could be underlying this child's geniverum with metabolic bone disorders, rickets, dysplasias, as we talked about. So let's talk about measuring them. Let's see, Trent, are you there?
Yes, I'm here.
All right. Tell me any ideas how you would go about measuring this child's legs?
Yeah, I mean, if you're looking specifically at the deformity for Blounce, you can do the metaphyseal diaphyseal angle. Looking for above 16, I think is certainly concerning, and then there's a gray zone. I think below is normal, then less than 13, and there's a gray zone in between, I believe.
Yeah, no, that's great. So yeah, Drennan's angle or the tibial metaphyseal diaphyseal angle is the more common one that we usually think about. And that's basically measuring a line between the 2 points of your metaphysis, 2 kind of beaks, and then down your shaft. And as you said, if it's less than 9, it's usually physiologic. In between, there's kind of a gray zone. We don't really know between 9 and 16. And certainly greater than 16, you want to be treating for Blounce. There's another angle that's being used as well, and that's the epiphyseal metaphyseal angle. And so a recent article showed that if you add that in, it can help you a little bit. Even if your metaphyseal diaphyseal angle, kind of no matter what that is, if your epiphyseal metaphyseal angle is less than 20, then they're low risk. And if you notice, so basically this line is drawn across the epiphysis or the physis, where the epiphysis is to the metaphysis, and then down the sloping part of the metaphysis. And if that's less than 20, then they're low risk. If it's greater than 20 and your metaphyseal diaphyseal angle is greater or equal to 10, then you really need to follow them even much more closely. So what do we see with infantile Blounce? We see widened and irregular physeal lines or medially sloped and irregular ossified epiphysis. You have kind of a prominent beaking. Typically, we don't see that until closer to at least 2 or above. Younger than that, you don't tend to see as much of the radiographic findings of these. But they can also have lateral subluxation. And then here's this Langenskold's classification, realizing that the more beaked they get and the worse off they get without fixing it, they get to a place where the bone is fused. So their medial physis is no longer going to grow. And that's really what we want to avoid, in these kids. So here's a patient that has Blounce, and you can see this medial beaking here and medial slope. And you can put them along this Langenskold's classification and look. Sometimes I find it difficult to look. We'll tend to get an MRI and look, and it's interesting to see how much cartilage here is actually along the medial aspect. There's a lot more there that's present than just what you see on the X-ray, and you have to keep that in mind when you go to correct it. because if you're elevating up part of your medial plateau, I'll do a joint arthrogram to see where that cartilaginous piece is, or what my alignment is, including the cartilage, because it is still there. It can still ossify at some point. Treatment for infantile Blount's. So, braces are a part of it. And when I see a young child that has it, like between 2 and 3, I typically will start them with braces. How well they comply with it. I do find if they comply with it, many of them do get better. And if they don't, then that can be a problem. So if they are still, worsening between that age of 2 and 3 or younger, if I'm worried about it, then I will brace them. And certainly if they're Langenskold's classification 2 and below. The braces need to be worn while they're weight bearing, because that's when the compressive forces are the worst. And so those I have found can be helpful, but again, for some kids, compliance is an issue. Surgical treatment, of Blount's. So an infantile Blount's, and this picture isn't exactly of an infant here, but it kind of gives you an idea. It's kind of what, is shown with the case with Genu valgum on Monday night by Dr. Abel, but we can implement growth modulation to try to make that happen, or to try to make that correction happen. And in this case, you'd put it along the lateral side, hoping that the medial side gets kind of offloaded and is allowed to grow more than the lateral side. And hopefully, this is a less invasive, obviously more invasive than braces, but less invasive than a tibial osteotomy. There haven't been, we don't have a lot of great studies yet to show that, at what point this should be done. And traditionally, we want to correct this alignment problem by a certain age. So let's see, does one of the residents, Trent, can you tell me, do you know what age, the recommendation is to correct this by?
I believe so you don't treat before 2, and then I think it's around 3 or 4, I want to say, when you start thinking of surgical correction.
Yeah, so you definitely want to, the critical age here is by 4 years old. So even if you give them less than a year, like say you see them at 3 and you put them in some braces and are not correcting, then you'd want to, make sure things are happening before then. And the ultimate question is, can you, put on those growth modulation plates and get the legs to straighten out, even if it's maybe a little bit past 4. That's possible if they don't have a significant amount of medial concern. But the traditional teaching is to do an osteotomy, overcorrect them a little bit, actually into a little bit of valgus, and get them improved by the age of 4. So here's just an example of your medial mechanical access to the joint line, doing a proximal tibia osteotomy. When they're young, you can just use K-wires and a cast, or if they're not too big, and straighten out their alignment here. Here's another one, but this child is a little bit older, so it's more of an infantile or late Blount's, and they're to the stage of 4, anywhere between 4 and 6 that we're looking at here. But this patient, again, like the MRI, I do, sometimes it's hard to really know if that growth plate is still growing or not. This was a patient I saw who had actually had a proximal tibial osteotomy about a year prior. So I saw him at about 6 years of age, and he had already recurred. They said he recurred extremely quickly. So I was really concerned about the medial growth plate here. And so, you do the osteotomy, but you don't want to just do that. You have to think about, okay, if this, 2 things. I mean, I did try to elevate the medial side. Doesn't look bony wise a significant amount better, but again, doing the intra-op arthrogram is helpful to know where that cartilage is, so you can raise it up to, appropriate joint line. And And then putting on this lateral plate is helpful too, for two reasons. You really want to, if this side isn't going to grow, then it won't recur if you put on that plate. If you've offloaded this side enough and it decides to grow, then you might start to head into a little bit of valgus, and you just have to watch that. And so you let that happen. If the growth plate is basically closed down, then it's closed down. And then you have to think about what to do on the other side. I have seen, surprisingly so, I've done this to another child a long time ago. She disappeared from my practice, showed up like 4 years later, and she was in a significant amount of valgus, even though I thought the growth plate was closed. So again, that was an important question I asked Monday night about that genuvalgum case. It's really important to follow these patients that you put those plates on very closely, because I've experienced it, that it's no fun to have them come back years later and now they're in the opposite deformity. But let's talk about, at this point, what do you do? So let's see, is Eric around?
Yeah, I'm here.
Okay, so Eric, on this x-ray here on the right, far right, we've done this osteotomy. His alignment looks pretty decent, but I think the growth plate on the right side is closed. So what are your options at this point to do for this child? What's going to happen, I guess, first?
How old is this is the child?
So he's 7 at this point.
7 years old.
That's right.
So 7 years old, having a closed physis on that side, open on the contralateral, is going to leave him with a fairly large, lib length discrepancy, given his potential for further growth. You have the depends on kind of how large the bar is at the physis. You could consider, a physeal bar resection, or you could consider contralateral, tethering or some procedure to epiphysiodesis to make the limb lengths equal.
Okay, so yeah, so we can either close down the other tibia, and hopefully he just, grows and doesn't have any leg length discrepancy, but they do have to know he'll be probably, if it's 6 centimeters of growth, because he'll, how much growth occurs in the proximal tibia a year approximately?
Proximal tibia gives you about 6 millimeters per year.
Okay, so 6 millimeters, and over maybe 10 years of growth for a boy, that's about 6 centimeters. So that's about 2 inches, to a little over 2 inches, 2 to 3 inches, that he'll be shorter. So that's certainly one option, is to close down that growth plate. And honestly, I think it's the easiest option. You close down both the tibia and the fibula. Don't forget about the fibula, because that could overgrow if you don't. But there are some families that are like, I don't want my kids shorter. And so then you can discuss that they'll need a lengthening later on, and you would need to lengthen their opposite, the short tibia. So, some of the issues with that is they may not have a completely normal knee joint. And if they do have some, subluxation to it, that could be in consideration if you're going to do a significant lengthening and concern. But it's something to discuss with the family, the different options that can be done. All right, so moving on to adolescent Blount's. So here we see an older individual with it. Again, this does tend to go in males, morbidly obese, also more so in blacks. This is when they're greater than 10. We don't usually know of any injury to the physis. It's usually unilateral in these cases, but it can be bilateral, and you have to look at the femur and the tibia. The tibia is usually the worst, but you may see some issues in the femur as well. A lot of them are asymptomatic, or maybe just come in with a little bit of knee pain. We don't really know why it happens, but we do think, again, that it may be some growth suppression from mechanical causes and being overweight. Their radiographs are very different than those with infantile Blounce or late infantile Blounce. You don't see the beaking that you see in infantile, but what you do see is actually widening of the proximal medial physis, which is an interesting thing given that it seems like it's a compressive force problem. But they also may have some widening, as I said, of their distal femur as well. So you really have to look at both. So there's really 4 components to tibia vera, and it's not just adolescent tibia vera, but any kids with tibia vera. You have to look at all the 4 components. So we know they have a varus malalignment. Dennis, are you there? Can you tell me if you know what other deformities they can get with tibia vera?
Yeah, I'm here. So I guess by having tibia vera, you would throw off the entire mechanical alignment of the entire limb. Is that what you're getting at? So like the
I was thinking
hip,
of
knee, ankle.
what other deformities within the tibia actually occur. So you don't just have a coronal view problem. What other?
I guess Bricker bottom or Proker bottom, one or the other.
Okay.
But
so yeah, it's a fully 3-dimensional problem. So you not only have the tibia vera, you have internal tibial torsion in most cases. You also have an increased slope of the tibia or Proker bottom, but it's very proximal. So it's really, just increased slope. And then a lot of times they're a little shorter on that side than the opposite side. So you have to think about all the different components. And if you're just going to correct, the tibia vera, but not the others, then, how much of it is a problem for them. So you have to think about it all. So what do we do to treat these? If they have growth left, then we can consider this growth modulation where we put some plates on. Can be very helpful, very powerful. It's less invasive. They can be very active, doing sports within a couple weeks after surgery, and doesn't correct all the deformities though. Again, if you think about the whole 3-dimensional piece, it corrects their tibial vera, but not necessarily their internal rotation or other things. So again, you have to, now sometimes that can be great. At least you correct the tibia vera, and then you can deal with some of the other issues, if needed later, and it's a much smaller surgery. Like you could do a derotational tibial osteotomy that's easier than correcting all of it at the same time. But you just have to keep that in mind. So here's just an example of, a patient with malalignment and genu varum bilaterally. We put on some plates and they very nicely corrected. And that's like, yes, that is awesome. And I'm, so thankful for it. Occasionally they don't fully correct. And so we have to do other things, or maybe they're to a stage where, their growth plates aren't that open, and we have to do other things. So what other things can we do? So we can do a valgus producing high tibial osteotomy with internal or external fixation used. And you can do it gradually or acutely. And again, if you use an external fixator, then typically you can correct all the different deformities and put in how much rotation they have, how much procurvatum they have, and all those different things, and fix them all. So here's an example of one of those patients who's a little bit more severe, decided to do a frame and correct all the different deformities. And he did well. So here, just an example of that. I also, if you notice, he had a plate on his distal femur as well, because the distal femur had a little bit of varus as well. So how do we know where the deformity is and what needs fixing? What measurements need to be made? And here's where we start going down the line of, okay, this is a little more, how to look at it and fix it. We saw a picture on my initial slide of something very complex, of deformity very complex. Where do you start with that? And so we need to look at what things to, or what do we need to look at? So for some of the younger guys, just some definitions: mechanical axis, a straight line between the center points of proximal and distal joints. You have an anatomic axis, which is down a diaphyseal path. And then some bones may have both of the same mechanical and anatomic axes, and others may be different. So here in the femur, you're looking at mechanical axis between the middle of the joint and the middle of the knee, and where is that line fall. And then you have an anatomic axis, which is different. That's the red line, basically down the diaphysis or shaft. And so those measurements and compared to the joint may be different. In the femur, they are, and in the tibia, they're actually the same. So we need to talk about alignment and orientation. So you have basically a mechanical axis. We're looking at this mechanical axis here, and how far from the midline does it go is your mechanical axis deviation, and how much, how far should it go? So normal is about 8 plus or minus 7, which seems like a large amount of difference, but basically 1 to 15 millimeters medial to the center of the joint is pretty normal. Your joint orientation is the position of the articular surface relative to the axis of the limb segment. And so here we can look at a mechanical lateral distal femoral angle, which is normally 88. Anatomic lateral distal femoral angle is normally 81. And your mechanical neck shaft angle, which most of you know from fixing hips, hip fractures in adults, is typically around 130 degrees. And then you have a lateral proximal femoral angle. And we're not going to go through all the details of this, but really this is all to say you got to know what normal is if you're going to start looking at deformity. And I'm just showing coronal, images, but you also have to look at sagittal alignment as well. And so all those pieces put together. So in tibials, joint orientation, again, looking at mechanical proximal tibial angle, your lateral distal tibial angle. So don't forget about the patient. Your mechanical axis may be fine, but from their hip to their ankle, but maybe their foot is abnormal. And so they have a lot of valgus or varus in their ankle, which may not affect your joint line from the hip to the ankle. So I have to remember all the different components here. A joint convergence angle. So they may have, MCL or LCL laxity, and so that may be part of their issue. If it's not, if that's not working well, then their joint convergence angle is going to be increased. Looking at their anatomic axis, as I said, going from, hip to ankle. And knowing what is normal there. Again, showing normal. I have a card with this that I carry around with me, on my badge to remind me, or to, that I can look to when I look at kids with abnormalities. Other definitions to look at: your chora, your center of rotation of axis, point of intersection of the proximal and distal axis lines, your angulation correction axis or axis line around which an osteotomy is performed, and your joint orientation, as we talked about, is the position of the articular surface relative to the axis of the limb segment. So when you're talking about correcting these, you kind of have to know what those things are. And I know this is a really quick overview for some of you younger guys who are just, coming into maybe seeing some of these things for the first time. But to plan, what you're going to do, you have to kind of have an idea in your mind where the deformity is. You can draw these different lines out. So starting with mid-diaphyseal lines, and then determining if those are normal or not, and seeing if you have uniapical or multi-apical choras. So are there multiple points of deformity, or do you just have one that needs to be fixed? Knowing what the normal, amounts are and where the deformity is really gonna, help you. So this is just a picture of, even having just shaft varus. So again, drawing those anatomic axes along the diaphysis shows you that. So that's your chora. Here's another patient. This patient had hypophosphatemic rickets, had already been tried by someone to put some plates on, and unfortunately that didn't help. So at this point, you see your growth plates are closed, but she still has significant malalignment. And here's her mechanical lateral distal femoral angle, which hers was 97 with the normal, which is usually 88. Anatomic lateral distal femoral angle, hers was 84 when normal is 82. And so part of that was she had that 9 degrees of varus in the femoral shaft, but she also has some, abnormality proximal and distal. Looking at her tibia, she only had a little bit of varus in her shaft, so really wasn't a significant amount. More of her deformity was in, if you measure her mechanical medial proximal tibial angle here, 75. But again, where is the deformity here? So then you have to go to, and sorry, just looking at a mechanical lateral distal tibial angle there, that was pretty normal for her. So we know it was probably more proximal deformity. We saw just a little bit in her shaft, but here, if we draw a normal medial proximal tibial angle of 87 and a anatomic lateral distal tibial angle, we find where the cora is. So cora is right, in the proximal shaft there, or metaphyseal area. How do we know, where to cut and what to cut? Well, there are 3 main osteotomy rules, and basically, if the osteotomy line and the angular correction axis are the same, then you basically can cut and straighten it out and not translate at all. If those are off, if your cora is off from your osteotomy, then the more translation and different things you have to think about to correct that. The bottom line with all that is to place your osteotomy as close to your cora as possible to prevent creating too much secondary deformity. And you need to account for that if you can't put them at the same spot. Looking at the same patient, so we were able to do a, put in a femoral nail to correct her varus deformity in the femur. We did use a blocking screw to make sure that we're able to correct it all, because if we didn't put that in, then the nail maybe would have been very likely to just slide down this lateral side, and we might not have gotten any good correction. So blocking screws can be helpful for that. Distally, you see we used frames, again, multi-axial frames with gradual correction. So you can use a mix and match of different things that can be done here to correct the deformities. So again, here she was, and here she is after the frames come off. And you could also see, going back a little bit, how much translation could occur, even though her deformity is probably a little bit above that, but still had to translate a little bit. And maybe we translated even a little too much, but overall alignment looks pretty good at that point. And here's just an example of an acute way to do an acute osteotomy for genu varum, and a very typical thing that we see frequently, an opening wedge osteotomy. Again, just have to remember that's correcting one plane for most cases, and not so much the internal tibial torsion or slope abnormalities as much. You can, try to tilt the back of the tibia up a little bit with that. All right, and we kind of went through the genu valgum a little bit the other night on Monday. And so I'm going to kind of click through these, and we talked about it a little bit, but just treatment of genu valgum. Again, hemiepiphyseal plating, growth modulation, very common to use with kids. Unfortunately, I do find that they get a lot of rebound valgus when you take the plates off. So you have to be careful. The timing wise, I feel like is sometimes challenging with some of these kids, but they certainly get a lot better by just a minor surgery of using growth modulation in most cases. So, but if modulation doesn't work or they're older, then we'll do, an opening wedge osteotomy of the distal femur to correct malalignment as well, similar to what you saw on the tibia. And sometimes with that, again, you also may have to think about, sometimes they're shorter on that side. Occasionally, you can get a little bit of length with your opening wedge, but sometimes it may not be enough. So you may have to consider lengthening as well, or a frame. This is an example of an 11-year-old. This is kind of my last case here. Interesting case. So I'd like one of the residents to tell me what they see here. Again, how about, let's go to a PGY5 again. I think I've gone through most of them, but Michelle, let's go back to you. What do you see in this picture?
Valgus alignment of the bilateral lower extremities.
Okay.
With proximal femur varus bilaterally as well. And sorry, it's hard to see the ankles on my phone, but the distal physes on the tibia as well look abnormal.
Sure. So they're kind of widened physes up here. This is a child who had had years of lower extremity pain and came into my office. I got these x-rays. I was like, whoa, there is something going on here. He, looks like basically he's got, coxa his growth plates, almost like slips, early slip capitofemoral epiphysis, and as well as kind of these widened growth plates. So he actually was in renal failure. His creatinine was 7. And the next day he came in and got dialyzed by nephrology. So, there are things that you can pick up on from deformity that can be life-threatening. But this patient, basically all you could do at the beginning, because his bones were like so soft, protect his hips, keep them from getting worse. And so basically we put in some skiffy screws just to hold him there until they, metabolically got him better. Then we, did some valgus osteotomies. We put on some plates and improved his alignment. And then you can see his alignment greatly improved at that point. So that's kind of an overview. I know it's a lot of information of malalignment. Hopefully some people took away some tips and thoughts about it. There's a lot more to explore if you're a resident and interested in limb deformity and limb alignment. So there's, a lot of courses to go to on those topics. So I'd encourage you to explore that if it's something you're interested in. But
that was great, Dr. Kuester, and I think well timed because a lot of this information is what is tested about normal torsional evolution in children, normal axial measurements and joint line measurements. Those are the kinds of information that are tested because they're easily verifiable. So I think it was a really good overview at this point in time. Let's take 5 minutes for questions. We went through cases, but if there are any questions or comments from Dr. Bachman or Ramnes, let's do those now before we start the next talk. Everyone good?
I got a question. Do you use any of the software for alignment issues? Like the Bone Ninja or any of the stuff available on PACS?
Yeah, so I have used Bone Ninja a little bit, but I'm not that technical savvy with it. I would say I'm still learning some of that. So I haven't used a lot of it.
No, the Ninja especially is really hard to use. Plus you have to have an iPad to do it. But.
Yeah. And I've seen the stuff on PACS too, because our total joints guys have some of that, but I haven't used that too much either.
Okay, well, let's go on and find out what we do in developing countries. Any other questions?
Hey, Mark, it's Dave Weiss. I've got a quick question.
Another question? Go ahead, Dave.
Thanks for those talks, Dr. Kuester. I'm one of the trauma guys here, and I do osteotomies in adults, or kids who don't get corrected when they if things don't finish correction, then I'll get them as an adult. But I had a quick question about your the discussions you have with the parents. A lot of times when you're talking about doing, you show X-rays where you've got corrections in multiple bones, and trying to determine, like when you talk the first case with the proximal measurement of malalignment, the tracking, those are big operations. There's a lot of surgery involved, and I was just curious if you have. I'm sure you get a wide range of parents. Some of them very anxious to avoid surgery. Some of them very anxious to have their kids sort of be as normal as possible. And I was curious if you had any tips for when you know that they're going to have a problem. How do you sort of relate to them the future? Doing an operation now versus waiting until later, trying to determine, what happens when they hit skeletal maturity. Those conversations are always, I think, interesting in how they play out. And, you can sort of maybe foresee the future, but it's hard to necessarily impart that to the parents or to the child as they get a little older and they're a teenager and maybe want to participate, even though legally the parents have to do it.
Yeah, those are all good points. So, and sometimes you have them come in for something totally different and you recognize that they have, miserable malalignment, but you don't want to tell that really to the family that they have that, because that isn't their complaint, right? They don't have knee pain. So I may, I won't say it that way, but I say, well, their rotation is a little bit off. But, I think there are a fair amount of people walking out there that have miserable malalignment without significant issues. So I don't put them in this category of you are definitely going to have a problem. But once they present to me with, leg pain, knee pain, and they do have miserable malalignment, then I honestly do try to do everything possible to not operate on them because it is such a big surgery. But if, you try the therapy, it's not working, you kind of have to, basically the family ends up coming to you like, I still want something done. And at that point in time, then, I think it's worth it to do a big surgery. But you kind of, yeah.
How do you handle the mom or dad who wants something done and the 14-year-old who does not want anything done?
Yeah, so it does depend on their age, but yeah, if I usually try to get them to come to an agreement, but I do obviously I tell you, you're the parent, and you have the right to to do what's right for your kid, and what is right. But I think their kid's going to come around. I don't think there's anything bad about waiting. I don't think you're creating, if it's not going to get better, then I would think the child eventually is going to come around to wanting it. So I don't think it's like cancer where you can't wait. So I tell them, hey, if it's that miserable for the child, miserable enough to do something, then I think they're going to get to that point where they'll decide they want it.
Thanks.
Okay, go ahead. Tori.
Okay, can you see my new screen?
Yes, I can see it.
Okay.
Yep, we're good to go. Thanks, Tori.
Okay, sure. And I just want to make sure, are you seeing my screen that's the presentation one, or?
I think we're seeing your presenter mode, Tori.
Okay, let me switch this again. Is that better?
You got it now.
Okay, great. All right, so this I just wanted to share, a little bit of my experiences, but also encourage, those in orthopedics to that there is work that can be done in other localities around the world. And I'm going to show a couple of different options of different ways to help. And so, yeah, I hope you get something out of this and it's a little more fun. But I've been a lot of different places. The two I've more frequently been to and more recently are Ethiopia and St. Vincent and the Grenadines. And so two different programs that I've gone to with these. When I go to St. Vincent and the Grenadines, I go with a group called World Pediatric Project. And we take a whole team. So World Pediatric Project does meet and work with the local physicians there, and we work with a local orthopedic surgeon who gives us cases that he's not comfortable with, and and we work closely with him in clinic and that kind of thing. But we take the whole team. And initially, when I was first going, we were doing general orthopedic cases. And more recently, we've been doing scoliosis trips. There is another team that goes and does general pediatric orthopedics. But the ones I've been with more recently, we do scoliosis. So we'll go down and do like 8 scoliosis surgeries in a week. And so with that, we take, anesthesia, We take our neuromonitoring rep. We take, a couple nurses for the OR, the rep for the company for spine hardware goes down. And so really you bring everything and everybody with you. And so we usually go for a week at a time. And we have like a day where we see, can be up to 100 patients in that day. And then we plan out, who we're going to do. And sometimes we bring 2 surgeons because it's exhausting to do 8 scolies in 4 days. And so that's helpful. World Pediatric Project helped to start an ICU in that location, which has been helpful to the hospital, not just for us, but for other people, for them in general, as well as other groups that come down. So World Pediatric Project also works with neurosurgery, plastic surgery, cardiology, and a lot of different folks. World Pediatric Project also will bring up complex patients to various hospitals, whether it's here or many other hospitals. They actually work now with a group in St. Louis as well, and join forces. This used to be called International Hospital for Children, and it's now called World Pediatric Project. So some of you may have heard about it. But again, we work with the local doctors there, but for the most part, we're self-sufficient when we're there. We bring everything with us, as I said. I mean, all the hardware, all the pretty much everything we need, but fluoro and a table, and everything else is brought. So it's a lot. A lot of it has to be sent ahead of time, and organization is part of it, and organizing beforehand, organizing when you're there. There's quite a lot. There are some educational opportunities with this, probably a little less so, but we do give a lecture to like the people at the hospital, as well as the local orthopedists. And we've had orthopedists coming from other islands that we invite them to come, when we're there for the week, and they're welcome to do surgery with us and learn. They may not be going back to do their own spine fusions, but they may get some other tips and things. And we learn from them just as much. So it's great to have the others involved. It's just a typical operating room in St. Vincent. Pretty well set up. We had to, figure out a table, since we use a Jackson table here in the States, at least I do. We had to, figure out a radiolucent option and how to set up rolls and that kind of thing. But it all works out pretty well. And fortunately, they do have a fluoro machine that we feel comfortable using. So this is a typical patient. When you go on some of these trips, you may be able to have dinner with very important people, like the Prime Minister, and sometimes that's fun to meet and greet and see that. This is just a spine surgery, so basically it's pretty much the same there as it is here. We are blessed to be able to have the whole team that goes, and I think to safely do something like this, that's what's really important, as well as to make sure that they have follow-up. So that's why we work really closely with the orthopedic surgeon there, so that he can do the follow-up. We are in close contact if there's problems or questions that arise from the cases. Earlier on, we were using a lot of mix between hooks and screws. Now, there's more older screws that we can bring and use, but the companies have been pretty gracious in supplying those for us. We get them up and walking. That was, we get them up and going, and amazingly so, they don't have many narcotics there. They have to get injected to get a narcotic, and they don't really like it. So most of them are just on Tylenol and ibuprofen, and they get up and move in the next day. I try to remind my patients here in the States about that. You can do this. You have narcotics, and you're still whining, but you can do it. All right, so the other organization that I've gone to Ethiopia with, it's been a little different opportunity. And so Cure International is a group organization that is mainly pediatric orthopedics. They do have some localities that have some pediatric neurosurgery and pediatric plastic surgery, but the majority of it is pediatric orthopedics. And so basically they have hospitals set up, about, I believe, 10 hospitals or so, mainly in Africa, but Tim Tebow has one in the Philippines. And there used to be one in Afghanistan. I think they've shut that one down, unfortunately. But so when I go to a place like this, I don't go with a whole team, but I'm basically going to be, support of however they need me to work for them. If one of their surgeons is out, then I try to plan to go when one of their surgeons is out, so that we can just kind of keep on rolling with cases and they don't get as backed up. I may come at, I offer my services to do basically whatever. They want to do difficult cases, together. I may bring, I do bring a fair amount with me, and but I don't have to bring all that I need for that week. So, they may ask for certain hardware. I bring extra hardware that I have. I brought a whole Taylor spatial frame set that I had put together with, things that I removed from patients and things that rep had given me, and was able to bring that to them. And fortunately, at a place like Cure, they usually have some international pediatric orthopedists. So at this locality in Ethiopia, when I first started going there in 2012, they had one pediatric orthopedist and one pediatric or one anesthesiologist. And since then, they have grown, and they now have 2 British pediatric orthopedists, 2 Ethiopian pediatric orthopedists that they've trained. They have residents coming through there from the Ethiopian orthopedic residency, and they now have a pediatric fellow. So tremendous growth. It's been exciting to be a part of and to see. Sometimes I wonder if I'm even necessary at this point, but different roles that can be taken. So it is exciting. Fortunately, with this one, as you can see, I can take my family, and they get to experience that area and country as well. So with this, I tend to go 2 weeks at a time. Again, I do bring some limited supplies. Unfortunately, Ethiopia particularly is very difficult with customs. It's one of the most difficult I've encountered to bring things into the country, medical supplies. I try to convince them and bring pictures of these are your kids that I'm helping, and still they charge a lot for bringing things in. So that's, it is what it is, and you just kind of work with it. The nice thing I love about going is teaching the residents and now fellows. And that's a big part, I feel like, of what is important about going abroad, is allowing others and Ethiopians to do what they can do for their people in their country. And now they have so many great generalists there that it's really nice for subspecialists to come and bring their expertise. So Dr. Kozin was bringing his expertise with hand surgery, and things like that can be really helpful. These are just some of the people there that I worked with through the years. Teddy and Mesfin are now the pediatric orthopedists that were trained, and they're just wonderful guys. And I learned so much from them when I go. They're deep in the trenches of doing really difficult things with not a lot of, not always as much as we have here. So it's really amazing to see them at work. There is a program as well with the anesthesiologist teaching CRNAs, and that's exciting. These are just people, the clinical nurses and floor nurses. Here's the operating rooms at Cure Ethiopia. And they, fortunately, USAID has helped bring in fluoro machines, and they're overall pretty well stocked. I mean, they reuse things amazingly. They reuse a Bovie like many times over, and their tourniquets get reused many times over. They just learn to work with it and do a really great job. What are some of the frequent things that we see in these developing countries? Blounce, limb deformities, a lot of that. And many different things. What's amazing to me, fortunately, they have in Ethiopia, one of the pediatric orthopedists did like a 6-month limb deformity fellowship. And so when I brought the Taylor spatial frame material over, he was able to use it probably even better than I can, honestly. So I'm very thankful that he has that and now has the potential to straighten out so many things and help these kids. DDH, you know, we see a fair amount of that and same type of things as we see here. AVN, we see, so there's a morsure osteotomy that we did to fix that. And now this was not, well, actually I took part in the very first part of this case and putting on the frame, but this was all the work of Dr. Tim Nunn, who was there. And you can see this patient had a burn. This is the foot fully like plantar flex 90 degrees the opposite direction. And he put on the frame and plastic surgery eventually came in and grafted. And unfortunately, you see a fair amount of burn contractures there because people still use a lot of open fires. But this is his final results, which I think is absolutely amazing. And just, you know, again, I don't know that I could have done that myself here. So, you know, they really do some great work. We see a lot of club feet over there, a lot of late club feet that wasn't Ponseti treated. Fortunately, at the Cure Hospital and all of the Cure hospitals, they have started Ponseti treatment centers and outreach Ponseti treatment centers, so they're casting. And so you don't see as many posterior medial releases, but it's still certainly more than we see here. And just your typical of, you know, Ponseti treatment that they've started. Fortunately, there's a group called Global Help that helps educate and hand out low-cost publications. So if you're ever interested in going abroad, and they have some, like they have a clubfoot Ponseti management catalog and how to make like a Dennis Brown bar. So you see here, this is a pretty typical one that you'll see in developing countries that Global Help helped to kind of come up with using, you know, resources that these countries have. And so unlike our very expensive Dobbs bar, they can use these others. Other things I do was doing complex syndactylies that you see, and you know, policization. This is not something I do that typically here, so I'm now happy that Dr. Kozin is going over there and doing things that's really his area of expertise. But see a lot of different things. Osteomyelitis, a Sudanese refugee who had this external fixator on for at least 9 months or more, had a significant issue. Again, I'm fortunate to be able to go with my family, and the kids basically go and do child life with kids in the hospital. You know, fortunately, the kids at the hospital aren't really sick, so there's the orthopedic problems. So my kids can be involved in cheering them up and playing with them. We also are fortunate to be able to go to some of the families' houses. We have a compassion child that we visit and support throughout the years, and we actually meet and greet him every time we go and see his life, and that's huge. So in general, I mean, you can experience beautiful people, beautiful countries, but there are, you know, some important keys to international work that I think about. And I think one of the #1 things is you have to go with a humble heart. When you go, it's so important for these, you know, these folks to know that you're coming, and I'm coming to learn as well. I'm not just bringing what I have and what I can do, but as I said, I can learn so much from the people there in so many different ways. And you know, they do more difficult club feet than I've ever done. So things like that are, you know, really important. Thinking about how to deal with not having a lot of, you know, whether it's hardware or casting supplies, or how am I going to do this in this situation is important. But no matter where we go and what we do, you know, we always have something to learn from others, and even medical workers or patients. And they've had experiences that we've never had. So these are just a couple of my experiences, a couple different options of going, as I said, one with a team, one just with an organization where you're going to that hospital. and different ways. There are different types of organizations. So CURE is more of a religious organization, Samaritan's Purse is as well, but there's others, Orthopedic Overseas and World Pediatric Project that are non-religious. There's also international courses to get involved in. So there are courses that they're sponsored by a variety of groups like POSNA. We have a group that helps with education in these developing countries. And so those are all the other ways to get involved. So actually the last time I went to Ethiopia, I went with Dr. Herzenberg to do a limb reconstruction course. And that was great. I mean, we had all of these orthopedic residents and surgeons coming and learning from what I would consider the best. I would say I was not, I'm not in that top tier of people with limb deformity like Herzenberg and some of the others he brought. I just happened to go because I, part of CURE in Ethiopia, and I wanted to be able to be a part of it and teach as much as I could. But I learned so much as well, again, from that course. And there's just, it's great to be a part of it. So, we were able to even have sawbones labs. We went to a cadaver lab. This again, Dr. Tim's, construct here. So much to learn from and see people. Now you can also bring international doctors here. So POSNA has an opportunity to bring international folks to POSNA training courses, and they can give scholarships to them, and you may help with that. But I brought Mesfin here to our house for a POSNA meeting and training, and then he could also experience my children's hospital as well. So just experience a different place, and that was a great opportunity. So those are the opportunities I have. I have a quick little video of just what CURE is like and what this does for folks. Hopefully this works. Hope. Maybe. Let's see.
Sometimes go right to the video if you have it on your hard drive.
Yeah,
Embed it in. Yeah, just do that. There you go. I will say that's very inspiring stuff you do, Tori, and I think that I can see how you have to be humbled. I would always worry that I didn't have what it takes when I got there, given the magnitude of the deformities. We're so spoiled here.
Yeah, I mean, just to follow up on that, I think it is a worry sometimes of, oh my goodness, I'm going to be overwhelmed. And honestly, I mean, you just take care of what you can and the best, and you do have to be careful of what decisions you make of who to operate on and who not to operate on. Again, I try to go to places and with groups that are going to have follow-up and are going to have, ongoing things, because it's hard to go to a place with a group and not have any follow-up after. Then I kind of wonder how much is really helping. But I feel like going to places that you can educate, as well as, work with the local surgeons who are going to give follow-up, and you can be in, these days with Zoom and emails, we can be in pretty constant communication with them. So those are helpful things.
Can you expand that
yeah.
screen?
See, I think I can do that.
There you go. Perfect.
Looking back at me, will we leave behind the innocent to grieve? On the road, on the run, when their lives have only begun. These could be our daughters and our sons. It's just like a drum, I can hear their hearts beating. I know my God won't let them be defeated. Every child has a dream to belong and belong.
Well, that was great. I think we have time for a few questions. One or two. Anyone have questions or comments?
So Tori, Bobby Chabra, thank you very much for your presentations. They're really fantastic information. And I have gone on a few mission trips as well. And what are your thoughts? It's very challenging to go to these trips because you don't have the resources, as was mentioned. And it tests your ability and skills in a way that you don't experience here at home in your institution because of the resources and support you have. So what are your thoughts as to when someone should go on these trips? Whether obviously during residency and fellowship, they'll have a limited role or because they have faculty there or attendings there. But as a faculty member, when do you think is a good time to go based on your experience? At what point in your career is my question.
Yeah. So, I mean, honestly, I really think you can go at any time. You can be of help depending on the trip that you go on, and again, learn a lot from it at just about any level. So, I mean, I first went as an orthopedic surgeon right before my fellowship year. I went with Dr. Sharps, and he took me. And so that was a great opportunity to kind of start seeing what I could do as an orthopedic surgeon. Prior to that, many of the trips I had been on I went as a medical student for 2 months. And so you can learn so many different things at different stages. And then, you know, how much help can you give? I definitely feel like as an orthopedic surgeon, I can give back to them a little bit more now that I'm trained. And I started going pretty early on into my career. So I think it's possible to, I think you can help and you can learn a lot at just about any stage. So I don't think there's a one time to go or, you know, right time to go.
Any other questions? Well, I got to say, Tori, that was really, really nice. Two great presentations.
Hey, Mark, can I ask a question real quick?
Oh, certainly, Rashad.
Hey, Rashard Dacus, I'm one of the hand surgeons here. I myself and the two chief residents went to Guatemala in January with Children of Americas, and I saw a bunch of interesting things. The most interesting thing was that the foot and ankle surgeon there was doing total talectomies, for complex club feet, and these kids were doing absolutely amazing. And so I think the thing I saw the most was that things that we just don't think about doing here, people were really accommodating well. And the last thing was they had an orthotist who was there, who would make a little kind of casting, so to speak, and they would follow up with him. And we had pretty good correspondence on WhatsApp with him even after, with follow-up for the hand splints and everything else, which I thought was really kind of important. But it sounds like having people on site who can follow up is probably the biggest thing that I saw as far as what determined whether or not we were going to do things that were complicated. Is that kind of what you see as well?
Absolutely. I so agree with you. Just having people there to do the follow-up, I mean, as you said, and do see the patients afterwards, make sure you're in contact with them, problems that arise, but also as you saw, I mean, you learn and you see things that are like, wow, that can be done, and it can be done more simply. You don't necessarily need all the millions of dollars of stuff that we have here, and they're really doing pretty well. So, yeah.
Good question. Sorry to cut you off. Anyone else? Go ahead. Okay, well, as I was
Mark,
saying, go ahead, Bobby.
I just wanted to say a few words here at the end, just to thank Tori for doing this virtually. It's a new norm for us. I hope you enjoyed the little gift package from UVA Orthopedics, and
Yes.
I know you've taken quite a bit of time Monday night and this morning from your practice, but we very much thank you for sharing your knowledge and experience. And of course, I want to again recognize Dr. Abel for everything he's done for UVA Orthopedics, for all of us as a mentor, friend, leader, and a patient advocate and educator. So I'm really excited that we have this lectureship in perpetuity, and look forward to future years.
Thank you, Bobby, and thank you, Tori. Thanks so much for the time. Please pass on my regards to Chester, will you?
Sure.
Chester and I
Happy to.
go way back. I went to, when I was in the Navy, I used to go, when he was with VCU, I used to go and review cases with him, and when they had the motion lab going there. So he and I go back to before 1990 when I started in '89. So give him my best, will you? And
Absolutely. Thanks again for
really
having me and
wonderful.
inviting me.
Yeah. All right. Well, we'll adjourn. Have a good day. I look forward to the next time, Tori. Take care,
All right,
everybody.
sounds good.
Thank
Thanks
you.
a lot.
Bye-bye.
Bye.